Okay, welcome to our unit on reproductive health, Unit 18. I was actually planning on starting this tomorrow. So we're getting a little jump on it. These are the objectives. We will just see how far we get. I plan on finishing up around 2 o'clock, just when we get to a good stopping place somewhere around 2 o'clock. So that will be our goal for the day. Okay, so women's health is what we're going to start out with gynecological issues such as infections, pelvic support disorders, reproductive tract disorders, breast disease, and malignant reproductive cancers. Our first objective is to discuss reproductive infections in women. These will include vulvovaginitis, PID, and toxic shock syndrome. So vulvovaginitis, what the vulva is the external genitalia, which you see pictured here. And so vulvovaginitis infections include any infection in the female external genitalia and the vagina. And what contributes to this, we already talked about when I was mentioning how trichomoniasis can be acquired non-sexually in postmenopausal women, and that's the change in the pH that happens associated with that change of life. Also, poorly controlled blood glucose levels. So women with diabetes are more prone to infections as well. And then changes in the balance of the vaginal flora, which can happen when antibiotics are prescribed or when anything foreign is introduced, such as bubble baths and douching. A compromised immune system promotes infection with, just like any other infection, also here, and prolonged overheating of the genital area, such as living in hot, humid weather and wearing tight, non-breathing clothing. Okay, so we're just going to talk about, there's 3 types listed here. The one on the bottom we already discussed, trichomoniasis. So we'll just focus on candidiasis and bacterial vaginosis. So candidiasis is a yeast infection, and it's just the overgrowth of the Candida albicans, and it's normally present, but when it causes problem is when it grows excessively. And signs and symptoms are burning and itching, and a cottage cheese type looking discharge. And it's treated with antifungal agents. Bacterial vaginosis, this is the one that the partner does not need to be treated. So sorry, for some reason I got that confused with trichomoniasis, which just know for all STIs, partner treatment is required or recommended. But the bacterial vaginosis is not an STI. It is caused by lactobacillus bacteria, and it does not require partner treatment. It has a grayish discharge, and it is distinctive because it is extremely foul smelling. In fact, providers talk about this, saying that it's the whiff test. So if you get a whiff of it and it knocks you over, then it's BV, they call it. So nursing care is to teach to avoid contributing factors. So like try to keep the blood glucose under control, avoid douching and bubble baths, etc. Avoid wearing non-breathing clothing. Teach signs and symptoms, which we just talked about, and help the client to feel safe and comfortable talking about these personal issues, because a lot of people feel uncomfortable bringing up things. Not at all. Because I used to work with when I worked labor and delivery at Lakeview Hospital, one of the nurses I worked with, she just worked on the weekends at the hospital. On the weekdays, she worked in an OBGYN clinic. And she said, don't live in a small, if you're going, this is your warning, if you're going to work in a gynecologist's office in a small community, don't live in that community. Because she said that wherever she went, people were constantly stopping her at the grocery store, at the restaurant, in the park, and describing their discharge to her. Because they recognized that she worked for the doctor and wanted free advice. So now you're warned, don't be that nurse who lives in the community to get questioned. Anyway, teach how to self-administer medications, because some things, they could be vaginal suppositories. The only time we ever recommend douching is if it's a medicated douche, which even that is not, it would be rare. I've seen them, like betadine douches, be prescribed before, but usually they don't use that much anymore. So, and then creams and pills. PID, we have already talked about. We're going to go in a little more detail in it now. It is an infection of the upper genital tract, and it migrates upward from the vagina. It can enter the uterus, traverse the fallopian tubes, and get in the ovaries, and then spread out from there. So it can cause quite significant damage in the pelvic area. Risk factors are multiple sexual partners, because it is a complication of STIs. Also frequent vaginal douching, because remember that just pushes the organism farther up the reproductive tract. And then IUD insertion. It used to be thought that having an intrauterine device, or IUD, increased the risk of PID, but it turns out that the only time it increases, there's a potential for increasing the risk for PID, is when the IUD is actually being inserted. So that just means that the provider needs to be very cautious in making sure there is no infection going on at the time of insertion. As long as there's no infection at the time of insertion, it can be safely inserted, and then there is no greater risk for pelvic inflammatory disease or infection associated with the IUD. Complications, we already talked about the infertility and ectopic pregnancy also causes pain and can also cause sepsis. So it is something that requires the immediate treatment by, let's first talk about the signs and symptoms. So it can be asymptomatic, but oftentimes there is pain, and as well as a purulent vaginal discharge, because chlamydia is the most common causative agent, and after that, gonorrhea, and also the new STI I mentioned at the very end, Mycoplasma genitalia. It causes also fever, nausea, and vomiting, painful urination, painful sexual intercourse, which is what this word dyspareunia means, and also backache. Okay, now for the treatment. Before we start treatment, we always want to get a culture and sensitivity, just to make sure that the antibiotics that we are going to be giving actually will take care of or get rid of the causative agent. And then we give IV antibiotics, usually triple antibiotics, so we have cover a broad spectrum. And and because usually it's caused by chlamydia, what are we going to give for chlamydia? I already quizzed you guys on this earlier, and you guys got it. But so yes, doxycycline and azithromycin, ceftriaxone if there's gonorrhea, and oftentimes We'll treat with flagyl, metronidazole as well. Okay, so laparoscopic surgery can be done to explore how serious the spread of infection is, and also to do a lysis of adhesion. So when the scar tissue develops, it can cause like things to stick together that shouldn't be sticking together, and that's part of what causes the pain. So they would just lyse those to detach the adhesions. And then you would want to test and treat the sexual partner and to educate to prevent future STIs. Okay, so the next infection we're going to talk about is toxic shock syndrome, or TSS. And that is generally caused by Staph aureus, and it's when it goes systemic. It can be very devastating to the body. It is associated, you do need to remember this, you probably already know it, but it's associated with super absorbent tampon use. What this chart shows is that back in the early 80s, a super absorbent tampon was designed and put on the market. And it was really popular because a woman could place a tampon and just forget she was on her period because it was so absorbent. It would absorb her hours and hours and hours. So the incidence of toxic shock syndrome shot up with that super absorbent tampon use. And of course, it was recognized right away, and they pulled it off the market. It was called Rely. And then so we saw a sharp decline right after that, but still it was relatively high to what it is more recently. It's been a gradual decline over the decades, and it just has taken lots of education and lots of awareness. So this is what we teach. At this point, since the incidence stayed relatively high compared to what it was prior to the super absorbent tampons, the FDA required labeling on the tampons regarding the absorbency levels. So that has slowly helped decrease the incidence. So signs and symptoms are use of a super absorbent tampon. So a woman would be on her period and using a tampon and then develop a sudden high fever and also sore throat, headache, dizziness, confusion, and a characteristic redness of the palms of the hands and soles of the feet. And what you see pictured here is that after the redness goes away, the skin on the palms and the soles peels away, like you see pictured here. So, and flu-like symptoms. So those are the signs and symptoms. Treatment is hospitalization for supportive therapy and IV antibiotics to take care of the sepsis. So this is what's important to teach all menstruating women is to be looking out for the signs and symptoms, to know what can happen, and that it's associated with using the more absorbent tampons than what your body requires. Women should be taught to just plan on changing their tampons every 2 to 4 hours, to not go any longer than 4 hours. So if their tampons are absorbent enough that they can go more than 4 hours, they should drop it down to the next level of absorbency so that they're not tempted to leave it, forget about it, and leave it in for longer than the 4 hours. And then it's also recommended to spend part of the day without having any tampons. So even though menstruation is flowing 24 hours a day, part of that day the woman should be off tampons, and it's recommended that it be during the night so that she doesn't have to get up during the middle of the night and change your pad after 4 hours. So just wear a pad at night. Wash hands carefully before inserting anything into the vagina. Don't leave female barrier contraceptions in place for longer than needed. and don't use tampons or female barrier contraceptives in the first 12 hours after giving birth. Okay, I just remembered I forgot to mention something when I was talking about treatments for, where is it? Vulvovaginitis. There's a home remedy, and you guys may have heard this. I'm going to take a poll. Yes or no? Have you heard that yogurt is helpful to treat yeast infection or vulvobacterial vaginosis? To help balance out the healthy bacteria. We've got the after lunch snooze going on. Not even half of you are responding. Wake up, guys. That got one more answer, too. Okay, I'm going to publish. And we're half and half. Oh, so I guess some of you didn't get a poll option somehow. Okay, so what we got, half of you had heard of that and the other half had not. So I want to bring this up for the half of you who have heard of using yogurt for a treatment, for a home remedy. There have been actually several medical studies on it, and it's inconclusive because, or equivocal, because just as for every study that says it helps, there's another study that says it doesn't help. What is determined is that they actually say eating yogurt helps, and some people even say inserting it into the vagina is helpful. And I just want to say to that, here's a rule to live by. Don't stuff food up your vagina. So, yeah, it actually does not help to put yogurt up the vagina. If it is placed in the vagina, it has to be non-sweetened because sugar is like bad in the vagina, but it's just best not to go there. Okay. Let's see. Stephanie's comment on TSS, is it related to the tampon material or leaving it in place? It is leaving it in place because the Staph aureus, it just creates a nice little cozy environment for the Staph aureus to replicate. So that's why you don't want to leave it in for very long, because just in case there is anything on the tampon, any Staph aureus, there are other agents, but that's the most common cause of it. So it just doesn't have a chance to settle in and grow there. Like, what is the correlation to the period cup thing? Don't they? Oh, I haven't researched that. Yes. That's a good point. TSS period. It is linked to it. Yeah. Yep. The period cup is linked to toxic shock syndrome. So that's something I actually just had made a note to research, and I just forgot to follow through on it because I got busy with other things. But yes, there is a link. That's a good, thank you for bringing that up. I'm not sure what the statistic is. Yeah, right. Doctors do mention that women can actually measure the volume of their cup, so they know exactly how heavy it is. Yeah, so you should empty it periodically. So I'm seeing mixed messages. I'm seeing some, without doing further research, the Lancet. Yeah, usually I like to check if there's mixed reviews. So some of the information that popped up said there's a link. Others say it's okay. So yeah, I'm sorry. I will research that and I'll let you know when we meet again. Which reminds me, I did research, what was it? C-sections and gonorrhea. So the CDC only recommends having a C-section for either herpes, active herpes lesions, or one I didn't mention is genital warts that would be in the way, that would cause significant pain and bleeding during vaginal birth. Yeah, so right, I will dishwasher safe. Yeah, so this is a kind of a new thing. Yeah, and it makes I even heard a doctor talking about it who said he said, so women are telling me the volume of their menstrual flow, which is awkward, he says, so even doctors find it kind of weird. So I guess after a while, it gets to be more of a norm. Maybe tampons originally people thought it was weird. And anyway, anytime there's something new out there, it generates discussion. Okay, so that's it for infections. And I will come back with more information on the cup as far as how it relates to toxic shock syndrome. Oops. So objective 2 is looking at the signs and symptoms, etc., interventions for structural reproductive tract disorders in women, which kind of makes me think of a collapse like this. So we'll be talking about cystocele, rectocele, uterine prolapse, and vaginal fistulas. So this is the pelvic support structure. It essentially the muscles and the ligaments that you see pictured here. And the idea is that it is supportive of the pelvic structures, kind of like a hammock. And pregnancy is really hard on the pelvic support system because of the weight of the pregnancy and carrying the weight of the pregnancy, and also because of the birth process. It's especially hard if the baby is large or there's multiple gestation. And it's especially hard if there's a traumatic vaginal delivery, such as requiring like forceps or shoulder dystocia, something like that. And it is also can be caused by scarring from STIs. And aging, that is actually the worst thing, is aging, because estrogen has a muscle toning effect, and when you lose your estrogen, you lose that muscle tone. So honestly, a lot of these pelvic support disorders we see are a delayed side effect of childbirth, and it's delayed because the combination of the history of childbirth, pregnancy and childbirth, along with aging, is when these tend to be manifest, although sometimes they are seen in even younger women just after delivery. So here's the first one we'll talk about is the cystocele. So the cyst refers to bladder because it's a fluid-filled vesicle. So the cystocele is when the bladder protrudes into the vagina. So this is normal here. And a cystocele, you can see that the bladder is tipping back into the vagina. And so it protrudes into the vagina. And the symptoms, just imagine what kinds of symptoms you would see if this is happening. And it's going to be stress incontinence, where if a woman coughs or sneezes, or if she maybe gets some catches something in her belly, in her abdomen, or jumping up and down, like jumping on a trampoline. It can can sometimes cause her to lose a little urine, a sensation of pelvic pressure, and also increased risk for urinary tract infection or an increased incidence of UTI. And it can be repaired surgically. The surgical procedure is called the anterior colporrhaphy, where they just kind of attach the and string the bladder up a little higher in the pelvis, so it's not dipping into the vagina. And that is not the only treatment. There are other treatments that can be given, can be done. Just a second. I have some pictures of the other treatments that they're called pessaries, so we'll get to that in a minute. There's also such thing as a urethrosil when it's the urethra that is protruding into the vagina, but that's a little detail you don't need to worry about. Coming from the other direction is the potential for the rectosil, which you can see pictured here, where the rectum is what's dipping, prolapsing or into the vagina, and it causes the signs and symptoms that you would imagine, which constipation, fecal incontinence, and again pelvic pressure. And the repair for that is the posterior colporrhaphy. And a lot of times women go in for surgery and they'll do what they call an A and P repair, which stands for an anterior and posterior colporrhaphy. Okay, the next one is uterine prolapse, where the uterus actually protrudes into the vagina, and there's 3 degrees of prolapse. The first degree is where it's just extending into the vaginal, prolapsing into the vaginal opening. And then the second degree is where it's prolapsed deeply enough that it extends to the perineal floor. And then the third degree is where you actually have it protruding outside of the body, which is kind of interesting that there's women who are willing to live with this. I've taken care of patients who've lived with that situation for a lengthy period of time, for decades. And once I was helping when I was working on the urology unit at LDS Hospital, there was a woman who was having a procedure the next day, and I was the night shift nurse, and she needed help getting up to the bathroom, and I got her up, and she was like all embarrassed, and she's like, "Oh, dread it popped out again." And she was just so adorable, but she's just like, "Just wait a minute." And she just kind of adjusted herself and got it resituated so that it wasn't falling out of her body. But yeah, kind of interesting. Let's see. It can uterine prolapse is it can cause back pain, pelvic pain, painful intercourse, urinary incontinence, constipation, and hemorrhoids. And plus, if it's third degree, plus the symptom of that little trivial point of the uterus hanging outside of the body. But surgical repair is to have a hysterectomy when the woman is finished with her childbearing. Prior to that, it can be surgically, an attempt can be made to surgically reposition it into the uterus. Okay, so these are the pessaries I was talking about, and what these can do is there's a variety of shapes and sizes depending on what's going on, what organ is prolapsing, but they can be placed inside of the vagina and help to support the structure that's prolapsing into the vagina to help prevent it from being in the way. And so these need to be specially fit and of course, diagnosed by the provider, and they should not be uncomfortable. So a woman should be able to wear them without experiencing any discomfort. They need to be washed periodically in warm, soapy water. The frequency depends on the design. And they also need to be examined periodically to make sure that, by the provider, to make sure that the fit is maintained. Because if a woman gains or loses a significant amount of weight, the fit can change. Okay, a good way to prevent pelvic support disorders is through exercise. Exercise is good, and here's a specific exercise for the pelvic floor. It's called the Kegel exercise, and it's just where the pelvic floor muscles are tightened and relaxed. And so the muscles, the way we teach to do this is we teach to tighten the muscles that you would use if you wanted to stop the flow of urine. We want to be clear that we're not asking people, and this can be taught to males and females, and it does benefit both males and females. So we want to be clear that we're not telling them to try to stop the flow of urine, because that's actually not healthy. We don't want people to actually try to stop the flow of urine, but we want them to kind of get the idea of how to contract their muscles would be to use the same muscles you would use if you were to try to stop the flow of urine. And they should be done many times a day, every day. And you can do lots of short, quick ones, or the elevator exercise, which is more of a prolonged one, where it's more of a slow increase in the intensity of the contraction, and then it relax. So either just a few of those or many of the shorter ones, like 20 or so. Some people suggest just having a reminder, a physical reminder to do it every day, like a picture on your mirror, or just remind yourself whenever you're stopped at the stoplight, while you're waiting at the stoplight, do the Kegels, or just have some sort of trigger that reminds you to do it every day, because it's good for everybody, no matter what their reproductive history is. It just helps to strengthen those pelvic floor muscles. Also, other things that are helpful to prevent pelvic support disorders are to have a healthy diet, because being overweight increases the problem, because that's more weight that the pelvic floor is trying to support. And also eating plenty of fiber so that there's less constipation. And we want to teach people to avoid smoking, because coughing, anytime a person coughs, they're exerting downward pressure on the pelvic floor. So if somebody is a frequent cougher, like a smoker's cough, then that is going to put more injury on the pelvic floor, repetitive injury. And then the pessaries, which we just talked about in the other slide, just teaching proper care of those. Okay, so yes or no, another poll. Who has heard of vaginal rejuvenation? You see it advertised a lot. You see it on billboards. You see it in those little, let's see. I don't know. Those mailers that come that have, here's one. I ripped it out of one of my mailers. Got a picture of a woman jumping happily on a trampoline, just like a little kid. I don't know if you guys can see that, but it's a Vivive. That's one of the brands. Anyway, I'll publish the poll. So most of you hadn't heard of it. Almost half of you had, and the other half had not. I just bring it up because some people have heard of it, and maybe want to know if it's a legit treatment. And actually, so far, it is not FDA approved. One of the treatments, let me remind myself which one it is. Oh, I have so much information on this. Oh, I've got it listed right there. This one here, the core, the O2, that's O2 for oxygen, core intima laser system. It claims to be FDA approved, but if you look at the approval, it is not approved for vaginal rejuvenation. It is approved for removing vaginal warts and cancers. That's what it's approved for. So there just haven't been enough tests done, long-term tests done on it to approve it. So there are some ongoing studies. So it may be approved. So far, the data that's coming out show it does seem to be helpful for some women, but it's not like a miracle cure, that it doesn't work well for everyone. So it's just something that a woman could bring up and talk to her doctor about, but as of now, it's not FDA approved. But be watching out for that in the future. Let's see, vaginal fistula. Fistula is when we've got an abnormal opening between two organs or two structures. So if it's a vaginal fistula, it's going to be between the vagina and a surrounding organ. So this is a rectovaginal fistula because it's an opening between the rectum and the vagina. The signs and symptoms would vary depending on which organ has the fistula. So type in the chat box, what signs and symptoms would you expect if there were a cystovaginal fistula between the bladder and the vagina? Yes. Yes. So there would be urine leaking out of the vagina. With a rectovaginal fistula, there could be fecal matter coming out of the vagina. So what causes vaginal fistula are sometimes they happen congenitally, other times they happen from obstetrical trauma or pelvic inflammatory disease. I don't have that listed on there. But that, yeah, infection can cause fistulas, and also Crohn's disease and surgical complications. So treatments are to repair the fistula, and also antibiotics to help to prevent the infection from spreading. Okay, reproductive tract disorders. So these are your uterine fibroid tumors, ovarian cysts, and polycystic ovary syndrome. Okay, uterine fibroid tumors. These are benign tumors, benign growth, and at least 99.9% of them are benign. And they are very slow growing, and they are fed by estrogen. So once a woman is menopausal, they will start to shrink away. And so a lot of times they don't require treatment. They would only require treatment if they cause significant symptoms like pain or discomfort. And they can actually grow to be so large that they impair circulation to areas in the pelvis. So in that case, they would need to be removed. And they can cause menstrual disorders. They can actually, forgot to mention, when they can grow so large that they impair circulation, and that can even include causing necrosis. So of course that would need to be treated. So here's just what we could do to treat them is to remove them. So which wherever they are, we would just, the doctor would remove them. Another treatment that became popular when a famous, a well-known politician, the former Secretary of State Condoleezza Rice, had this treatment done, and then a lot of women were like, hey, I want that. So it's called the uterine artery embolization. So it's kind of like a heart, what they do for heart catheterization. They go in with a with these granules that will settle in to the area that supplies the circulation, where that feeds the tumor, the fibroid, and it blocks circulation to that fibroid tumor, and then it will shrink in size. And so instead of having a surgery done, they just do that. The problem with that is that it is not good to do that if a woman wants to get pregnant later. So it's not recommended if a woman wants to attempt another pregnancy. And they can also give hormones to suppress estrogen, like a pseudomenopause. Okay, ovarian cysts are fluid-filled sacs inside of the ovary. You can kind of see pictured here. And most of these are caused by incomplete ovulation, where an ovum starts to develop, but it doesn't finish the cycle, finish the production. And complications are hemorrhage, torsion, or twisting of the ovary, and infection. The symptoms are lower abdominal pain or pressure. Usually it's just on one side or unilateral. And treatment is honestly just watchful waiting to see if it causes para-ovarian cysts. No, I'm not quite sure. The type of cyst forms near an ovary. Okay, so that's the difference. It's not in the ovary, it's near the ovary. They won't adhere to the internal organ. These cysts often dissolve on their own or go in undiagnosed. So yeah, that would require treatment, I guess, just if there are symptoms. Just kind of similar to the ovarian cyst. So they can be treated by oral contraceptives to regulate the menstrual cycle, and it allows the cysts to regress and prevents additional cyst formation, and also can be removed surgically. Oh, I forgot to warn you. The largest cyst that there ever was, the largest documented cyst, was an ovarian cyst, and it was 300 pounds. This is what it looked like. Okay. Usually when I show this in class, there's an audible gasp. Yeah, the question is, how does a woman live? I think she weighed, after they removed the cyst, she weighed less than the cyst did. I think she was, so in class before, I've had students actually Google this and be able to report on details, but the cyst, the woman weighed 200 pounds after removal, and the cyst was 300 pounds. They had to remove it as a single unit because they thought they could just cut it up into smaller, but just with the way the circulation was intertwined, they had to remove it as a whole piece. And when they were done with the surgery, she went out on one gurney, and the cyst went out on another gurney. It was a multicystic mass. It had a diameter of 1 meter, so it wasn't as huge as what it looks like. Well, 1 meter, that's 3 feet. Yeah, it looks about right. And it was a 6-hour surgery to remove it. Anyway, yeah, it's amazing. Sometimes people just don't seek medical treatment thinking it'll go away on its own, but obviously that one did not. Did they give her a tummy tuck too? You know, it seems like they would have had to remove some of the skin. Okay, now let's talk about polycystic ovary. I always want to say ovarian syndrome. It's polycystic ovary syndrome. And they are working on changing the name from polycystic ovary syndrome to metabolic reproductive syndrome, because it's more similar to metabolic syndrome, and it having cysts on the ovaries is not even a required. A woman can be diagnosed with polycystic ovary syndrome even if she doesn't have polycystic ovaries. There are 3 symptoms, and only 2 of the 3 may be present. So if she has the other 2, she wouldn't even need the cyst. So the first, and actually this is the one that's more universally seen in all women with polycystic ovary syndrome, is oligoovulation, meaning that there are infrequent or irregular menstrual cycles. In the past, well, it's like if a woman has less than 9 periods a year, that's considered oligoovulation, but you don't need to memorize that detail. The second symptom is hyperandrogenism, which is virilization, meaning male hormone symptoms, which there is androgen. So androgen is considered to be more of a male hormone, and there is androgen in the ovaries, and a healthy ovary needs to have androgen in it, because if it weren't for the androgen in the ovary, doctors explain it this way, that the ovaries would just be popping out eggs all the time, just like popcorn, just like constantly producing ovum. So we do need to have androgen in the hormone, androgen in the ovaries. So the problem is with polycystic ovary syndrome is that there gets to be too much androgen in the ovaries, and I'll explain why that is in a minute. But the excessive androgen hormone in the ovaries causes male pattern symptoms, such as male pattern baldness, facial hair, severe acne, okay, which you see pictured, and also polycystic ovaries, which if you were to do an ultrasound, you could look and see that there are a lot of cysts in the ovaries. So this condition is associated with insulin resistance. So we see it more in diabetes and also obesity. So obesity is another symptom, but I mean, it's not one diagnostic symptom. And it increases the risk of having polycystic ovary syndrome, increases the risk of acquiring diabetes. So if you didn't have it to start with, you're more likely to have it after you get it. And it also increases the risk for heart disease, hypertension, depression, and anxiety. Sorry, I'm just wanted to explain the relationship between insulin and the hyperandrogenism. Do I have it on another slide? Sorry, this is something I would have reviewed and had on the top of my head better if I was giving this lecture tomorrow when I was planning on it. But I just want to make sure I don't make it confusing as I explain it. Okay, yeah, I guess I do have that here. So the treatments are lifestyle improvements, which are to give a healthy diet, and encourage people to eat a healthy diet and exercise for weight control, and also having good blood sugar management and decrease consumption of caffeine, alcohol, and cigarettes. So medications, we often treat polycystic ovary syndrome with metformin, such as glucophage, and it is an oral hypoglycemic. And what that does is it treats insulin resistance, because remember on the first slide we said it's associated with insulin resistance. So and that decreases the hyperandrogenism, because this is the detail I was wanting to clarify. Hyperinsulinemia stimulates androgen production. Okay, so that extra insulin circulating stimulates extra androgen in the ovaries. So that's why we give the metformin to get the insulin levels under control. And oftentimes that just the metformin is all it takes to restore normal ovarian function, and it also helps to facilitate weight loss. So there's lots of good outcomes associated with metformin. And then women may also be treated with hormones, depending on whether or not they want to try to achieve a pregnancy. So if they are not trying to get pregnant, we would give them oral contraceptives, and that improves menstrual regularity, because remember, one of the symptoms is oligo-ovulation, where they don't ovulate regularly. And the oral contraception also decreases virilization, like the symptoms like acne and facial hair growth and male pattern baldness. If a woman is trying to conceive, then she would be treated with ovulation-inducing medications, such as Clomid. And often this is used in combination with metformin, but really, more often than not, just the metformin alone is enough, without the addition of an ovulation-inducing medication, is enough to get the ovaries functioning well enough to ovulate, and so that she can achieve a pregnancy just on the metformin. So women need to be prepared for that, because a lot of times their understanding is that polycystic ovarian syndrome causes infertility, which it does because of the oligo-ovulation and the hyperandrogenism, etc. But once you take care of that hypoandrogenism by treating the hyperinsulinemia with metformin, they're going to be fertile. So a lot of times, unless you tell them, now once we treat you, once we get your weight at a good, also losing weight, losing 10% of their body weight helps to restore ovulation. So women need to know that once they get proper treatment, they will now be fertile, and they need to be prepared for that and decide if they want to achieve a pregnancy or not. Because if they don't, they need to start with oral contraceptions at the same time they're treated with the metformin. Okay, this is just an FYI going down the rabbit hole while we're talking about cysts. There is, and this is not anything you guys need to know. You've got notes for it in your PowerPoint under the notes section, but there is another type of cyst is the dermoid ovarian cyst, which is a type of teratoma. It's a germ cell tumor which develops from the ovary. So it's interesting because it can have tissue that you would find in an embryo, like skin and teeth and bones, like bone cartilage. But it is not a fertilized egg. It's just from the germ tissue itself. And these can be found in both male and female. So the male equivalent is the testicular teratoma. And then there's a fetiform teratoma, where these can actually be found inside of a developing fetus. And they're pretty rare, but sometimes they're considered to be a complication of twinning, where one twin develops inside of its own twin. So that's fetus in fetu, which is a little different than the fetiform teratoma, which is when you've got a dermoid cyst growing inside of a fetus that is not a fertilized egg. Okay, let's talk about breast disorders, and then we'll break for the day. All right, mastitis is a breast infection of the mammary gland, and it is seen most commonly associated with breastfeeding. It can happen in women who are not breastfeeding. Usually we only see that happen in women who are heavy smokers with poor nutrition and poor hygiene. But I could never find any statistics on what percentage of mastitis is from breast feeding women, but I'm thinking it's in the 90 percentile or better. So since it is associated with breastfeeding, it happens after giving birth, and breast milk is being produced. And it's when it happens when the breast is not, the specific mammary gland is not fully emptied frequently enough. So let's say the woman is feeding her baby, and the baby isn't very hungry, so doesn't complete the feeding. So there's still some milk backed up in the mammary gland, and before long, if it's allowed to sit there, it can the duct can become clogged, and then it becomes infected and inflamed. It's also associated with cracked nipples, because that could allow microorganisms to enter the breast area. It causes flu-like symptoms, so a fever, and also a reddened area on the breast. So just like you saw pictured here, the area where the infection is, it will be red and inflamed and very tender to the touch. So very painful for the woman. So if a woman who's breastfeeding comes in with a fever and an area on her breast that is reddened and tender, you're going to suspect mastitis. We treat it with antibiotics and pain medications and warm compresses. The warm compresses help with comfort, and they also help, along with massage, to expel the milk that's backed up in the mammary gland. So we teach women to, when they're breastfeeding, or anytime, to just use good hygiene and wash their hands before breastfeeding, and to make sure that the breast is emptied with each feeding. So even if the baby doesn't finish, the mom can express what milk is left behind just by massaging And as she's breastfeeding, you can teach her to massage and feel if there's any areas that are feeling hard or lumpy. That could be a clogged milk duct and milk filling up in the mammary gland. So just teach her to assess for that and to massage it until it softens up, which means that it's cleared from the mammary. It's cleared the blockage in the duct. And encourage to continue breastfeeding while they're being treated for mastitis, because that's just going to help with the circulation in the breast. All right, fibrocystic breast disease. These are benign cysts, and they are usually palpable, and they are treated by a needle biopsy where the provider would go in and draw the fluid out and to empty the cyst. And then I would send that down for a biopsy just to make sure, to see if it's cancerous, and which typically the water filled, when there's a fluid in the cyst, in the lump, it's not going to be cancerous in most of the time. Okay, but they still have to check it just in case. And these can be quite painful, so women, we also would offer women pain medication, analgesics. Okay, now we're going to move into talking about cancer. It's the only I'll look at the time when we finish talking about breast cancer. Okay, so the estrogen effect, what that is women with increased exposure to estrogen are at increased risk for most of the gynecologic cancers. Right. So these are the things that can increase the amount of estrogen exposure that a woman has. First one we'll mention is menstruation related. So a woman who has an early onset of menstruation or an early menarche, which by definition is less than age 10. So if she starts her period when her age is in the single digits, that's early menarche. And also late menopause. So a woman who, by definition, ceases menstruating after age 55. Okay, reproductive related estrogen exposure is a woman who never is pregnant, because women who are pregnant, the placenta takes over producing the estrogen that the body needs, and that estrogen, the estrogen that the placenta produces. Let's see. This is another detail I would have reviewed to be able to explain a little bit more clearly. Just a second. That's super detailed, but anyway, I don't need to get into that, but I'll just keep it simple by saying women who have never been pregnant or had their first pregnancy after age 25 or never breastfed, those all increase the exposure to her exposure to estrogen over her lifetime. So these are all risk factors for the gynecologic cancers. And then there's 3 lifestyle-related things that contribute to higher estrogen levels. Obesity increases estrogen level, eating a high-fat diet, in part because that contributes to the obesity, and also taking estrogen replacement therapy. And we'll talk more about that when we talk about menopause. But so all of these things listed here increase the risk of the gynecologic cancers, including breast cancer. So breast cancer is an abnormal cancerous growth of the breast cells, and it's the second leading cause of cancer death in women. The leading cause of cancer death in women is lung cancer. And 1 in 8 women in the United States will develop breast cancer over the course of their lifetime. Risk factors are all of what was on the previous slide, the things that increase estrogen in the woman's life throughout her lifetime. A personal or family history of breast cancer, because of some cancers, if you remember from our genetics lecture, if the woman has the BRCA genes, either of the BRCA genes, she has a significantly higher risk of developing breast cancer. So if it runs in the family, it could be that that gene is running in the family. Eating a high-fat diet, again, because of the obesity, high alcohol intake, smoking, extended exposure to estrogen, like all of those things on the previous slide, and having dense breasts. This is a more recent development or acknowledgement that women with dense breasts have increased risk. So that's just something that women might want to ask their providers if they can detect with a mammogram, or that if their breasts are particularly dense. So women can reduce their risk of developing breast cancer by avoiding the starred items. So avoiding eating a high-fat diet, avoiding high alcohol intake, and also avoiding smoking. Increasing age. I think I skipped over that. As a woman gets older, her risk for developing any of the reproductive cancers increases. So we screen for breast cancer, as you guys know, from by using a mammogram, which is an X-ray. That picture did not show up. You can almost not even see it. It's so dark. But it wasn't like this on my slide. I don't know why it turned out so dark. But anyways, this is a woman getting a mammogram. So the recommendation for mammograms is women 40 through 49 it's her choice whether she wants to have mammograms or not. And then between ages 50 and 75, it's recommended that she get a mammogram every 2 years. We no longer, ACOG, the American College of Obstetricians and Gynecologists, no longer advocates for breast self-exam, and neither do any of the medical organizations. So we're not teaching people to do breast self-exams anymore. However, we do teach that women should be familiar with what's normal for her and to report any changes. So we are not teaching breast self-exams, but we're teaching breast awareness, which looks a lot like teaching breast self-exams. But anyway, there are still NCLEX questions on. So when you sit for your nursing license exam, you may get a test question on this. So we threw this back in, even though we're not supposed to be teaching people to do this. We do need to be aware that premenopausal women, the best time to check their breasts or assess their breasts is about a week after their menses, because that's where there's the least amount of swelling or fluid in the breasts. And they should just choose do a visual exam and a manual exam, just feeling for any abnormalities and observing for any of these sorts of things. Like this is supposed to represent an orange peel texture of the skin of the breast, which indicates there's some lymph involvement going on, a lump or a thickened area, and those oftentimes just turn out to be cysts, but they still need to be checked out. Redness like this, that would indicate mastitis. We don't see redness or inflammation in association with breast cancer, but it would still need to be treated. Nipple changes, discharge, bloody discharge is always concerning, if especially if it's coming out of a single duct, and any vein growth. So just be watching for those things. Breast cancer treatment, depending on how early it's caught, they may be able to, if they catch it very early, they may be able just to do a lumpectomy, where they just remove the breast lump. Often, though, it requires a mastectomy, and so a mastectomy is a removal of the breast tissue. I'm going to skip over well, actually, I'm not. I'm going to go to modified radical mastectomy. This is the most common treatment, surgical treatment for breast cancer, because usually we don't catch it early enough to get by with just doing a lumpectomy. And if there are any lymph nodes involved, then it needs to be a radical mastectomy. So that's what radical means, is that you're removing not only the organ, but also the surrounding or the associated lymph nodes. So a modified radical mastectomy means that they just, right here, pictured here, where they remove the breast, the lymph nodes, going up into the axillary area, but they leave the muscle in place. That's why the modified part of this means that they're leaving the muscle. A radical mastectomy is where they remove the breast, the lymph nodes, and the muscle. So that is by far more invasive. So fortunately, those are only rarely need to be done. Let's see. So breast nursing care for women with breast cancer is to assess for if she's ready to talk about her altered body image, and give her some counsel and encouragement with that, and encourage her to focus on the positive changes instead of looking back with regret, just to look forward with hope and expectations for the life ahead of her. Assist with building strength and mobility. Manage the hormone therapy related side effects, such as hot flashes and vaginal dryness. Prevent lymphedema. So when the lymph nodes, this is only concern if the lymph nodes were removed. So if the lymph nodes were left in place, then we don't worry about lymphedema. And actually the more recent procedures, they're able to take care, they are less invasive. So lymphedema isn't as huge of a problem as it used to be. But if you see a woman, a sign, if you're taking care of a patient who had previously modified radical mastectomy, there may be a sign at the head of her bed or somewhere that says not to take blood pressures or venipunctures or any blood draws or IVs in the affected arm. But that depends a little bit on how invasive this, how many lymph nodes needed to be removed, etc. Because it is possible that they, actually, I'm not going to muddy the waters. Okay. Sometimes I just want to give you too much information, but okay, so we'll just keep this clear and simple. So no sticks. We'll just say that if she's had a radical breast surgery where the lymph nodes are involved, no needle sticks on the affected arm. Elevate the limb to avoid blood pooling. So that helps, keeping her limb elevated will help the fluid to drain to her heart, and then teach the woman to avoid risk of infecting the affected arm, because it would have delayed healing because the circulation isn't as good. The lymph circulation isn't as good. And teach her not to carry anything heavy in her affected arm, and not to wear her purse or her handbag on that shoulder. And she should be encouraged to exercise to develop collateral lymph circulation. So exercise is a good thing. Just don't overdo it. I think that takes us to the end. Yeah. So we will start up tomorrow afternoon on Objective 4. All right. Have a nice afternoon, and we'll see you tomorrow. Oh, yeah, Stephanie, I didn't see your question. So you pump post-feeding. Yeah, you could do that just to make sure that the breasts are emptied with each feeding. Oh, okay, I did get that. Okay, good. All right, we'll see you later.